Again, I'm giving our NAPLEX review presentation today. I'm going to be going over drug references, biostatistics, and pharmacoeconomics. So I'm going to start right off with prescribing information. First, I'm going to go over some of the most common resources that are available to pharmacists and to pharmacy students, what kind of information they can provide, and who the intended audience is. So the prescribing information, you also hear it called the package insert. It's put out by the manufacturer of a drug. There's a standard formatting, and there's certain information that it's required to have that the FDA checks as part of the approval process when a new drug or the generic is approved. The PI, it's written at the level of a healthcare professional. And here's a screenshot where I kind of outlined some of the important sections. This is the very first page. It's like kind of a summary of the most important information in the prescribing information. This is for the brand name Reglan or metoclopramide. And so these sections are probably what you're going to be looking up the most. That's why they're right up front and summarized. Right after the name of the drug, you see any black box warnings that it has. So a good way to check if a medication has a black box warning is to go find the prescribing information because it'll be right up front. And then it also has all of the FDA approved indications summarized. One disadvantage of prescribing information is that it doesn't have any information on off-label uses, so you have to go to other sources for that. It also has basic dosing information, a summary of any absolute contraindications, important warnings and precautions, a list of the most common adverse reactions, and then a few major drug interactions on the first page. So in the red box here are the rest of the sections of the prescribing information. For special populations, they always have sections on pregnancy and lactation, pediatrics, geriatrics, and hepatic and renal impairment. And then they might have a couple other that are specific to the medication. There's not always a ton of information under these sections. Like under pediatric use, if there haven't been any pediatric studies conducted that have been put on the labeling, it'll just say safety and efficacy in pediatric patients hasn't been established, and that's it. Even if it's something that is used in pediatric patients, if it hasn't been submitted to the FDA to be put on the labeling, it won't be on there. So a few places to find prescribing information. I wouldn't recommend just trying to Google it because a lot of times you might end up with an old version that doesn't have the newest updates. Drugs at FDA is a really good place to get it. Search by the proprietary name because for some reason, if you search for the generic on drugs at FDA, it won't always link it to the brand name, and the generics won't always have the prescribing information linked. So just searching by the brand is the easiest way to find it. And then DailyMed is like the website version of prescribing information. It's nice that it links to MedWatch, the FDA recalls and drug shortages, and also LactMed. So you can go right to those sites from looking at the prescribing information for medication if you want more. You can also find labeling on the manufacturer's website, usually just for newer brand name medications. And there's always a paper version attached to a stock bottle. This is a screenshot of what the Drugs at FDA webpage looks like. So you just type in whatever drug you're looking for into the search bar and you can get to the prescribing information. You can also get to the entire approval package, but there's quite a bit of information in there. It's all of the stuff that the manufacturer submitted to the FDA to be reviewed to get the drug approved. This is a screenshot of DailyMed. It's literally just the prescribing information in the form of a web page. And you can see on the left side of the screenshot, underneath the picture of that physical label, it links to MedWatch and the FDA website and LATMed. And just a little more information, you guys probably know this, but black box warnings are if there's a serious risk of death or permanent disability in a certain population, or if a patient has a really bad reaction, just anything that's come up with that will get added as a black box. Contraindications are populations that shouldn't have it because the risks outweigh the benefits. And then warnings and precautions, those are the more serious adverse reactions that aren't quite black boxes or contraindications, but could cause serious reactions or teratogenicity. So here's a chart of some of the common drug resources and the type of information you can find. I basically copied it straight out of the book. It's on page 89 of the 2021 NAPLEX book. It's definitely something to be familiar with, just knowing in general, if you wanted to know if an IV drug was compatible with another one, which source can you go to find it? And then Pharmacist Letter is a monthly newsletter you can subscribe to that sends out some cool information. You can also find CEs there, which we're all going to need when we're licensed. You do have to pay for it though. Okay, so OTC labeling, it's different from the prescribing information on for prescription drugs. It's written at the level that an average person without medical training should understand. And it's submitted to the FDA for review when the OTC gets approved or gets approval for going over the counter. It has a standard format and standard information that has to be included, like the active ingredient, the uses or indications, any major warnings, contraindications, populations that should ask their doctor before using it, and the directions and dosing. And so clinical guidelines, they're essentially just literature reviews by a panel of experts who give clinical recommendations based on that evidence that they find. They're intended to promote evidence-based treatment of conditions and kind of help standardize treatment. For the NAPLEX, you should know what the major guidelines are, what they're for, and the organizations that publish them. So for example, if you were looking for COPD guidelines, you should know to look for the GOLD guidelines. And a few other sources that are good to know about. Through the FDA, there's MedWatch for adverse reactions. The VAERS is for vaccine reactions, for reporting them. And drug shortages and recalls will have daily updates of any new shortages or new recalls nationwide. The color drug references all have a different genre of information. Orange book is for approved bioequivalents. A pink book has information on vaccines. Purple book is biologics. And the yellow book has information on international travel, any medications or vaccines you might need. And then, oh, I skipped the USP books. Okay, USP 795, non-sterile compounding, 797, sterile compounding, and 800, hazardous drugs. And then finally, to find primary literature, there's a lot of good places to find stuff, but PubMed and Cochrane are two of the big ones. A few reliable resources to recommend for patients. For general health information, there's Health Finder, which is put out by the Department of Health and Human Services. Medline, the CDC, Mayo Clinic, and WebMD are all okay, and all written at a level that patients will understand. For medication information, fda.gov/for-consumers, drugs.com, which it's actually kind of linked to the FDA websites, They have information on like drugs, the shortages and recalls, and new drug approvals. rxlist.com is another one that has information on specific medications, and then safemedication.com. Okay, any questions on drug resources? Okay. So now we're going to switch gears a little bit and talk about biostatistics. So we'll start with different types of data. Data can be continuous or discrete. Continuous means that the values for the data, for the measurements, exist in a logical order with a continuous difference between values. So for example, if you're weighing something, logically you know that 5 grams is lighter than 6 grams, which is the logical order, and the difference between 5 and 6 grams is equal to the difference between 6 and 7. So that's an example of continuous data. And then you can further divide continuous data into interval and ratio. Interval data is continuous data that has a meaningful 0. So that means that the measurement of 0 is the absolute 0, and you can't measure anything below that. And I put a little scale underneath that because weight is a good example of this. You can't measure a negative weight, it's impossible. So because 0 is absolute, there's nothing. And then ratio data is continuous data that doesn't have a meaningful 0. So you can have negative measurements. And a good example of this is temperature in Fahrenheit or Celsius. Discrete data can also be called categorical data. This is when data points are sorted into categories based on some characteristic or measurement. And then you can divide discrete data into ordinal and nominal. Ordinal data is where the categories you're sorting them into have some kind of logical ranking or order. So a good example of this is letter grades. It's discrete because you're taking the scores and just sorting them into categories. And it's ordinal because there's a logical order. Like you know that an A is higher than a B, which is higher than a C, and you can put them in that order. Nominal data is discrete data with categories that don't have a logical order. So for example, like types of farm animal, you can sort each animal into the category, but if the categories are only the type of animal, there's not really an order to sort them into. And another example of nominal data is anything that's like a yes or no question. So measures of central tendency and variability are a way to summarize data and quickly give useful information about it. Our measures of central tendency are mean, median, and mode. And for variability, it's range and standard deviation. The best measure of central tendency to use for your data depends on the type of data, and if it's continuous, also the distribution. So this little table here up top I made, it shows, first of all, which measures of central tendency are even possible to use with each type of data. So with nominal data, which is where you're just sorting into categories that don't have an order, like species of farm animal, you can only really use mode. You can't find median or mean because there's no highest or lowest category. And with ordinal data, like with letter grades, you can do mode because you can find which one has the most data points sorted into that category. And you can find the median because you can put the categories in a logical order. But you can't find a mean because you can't like add a letter grade C to a letter grade A. It doesn't make sense. And for continuous data, you can always find your mean, your median, and your mode. One interesting thing to think about is knowing which measure is best with continuous data and which one is most reflective of the actual central tendency, because that changes based on how it's distributed. These graphs below show that the one on the left has a normal distribution, which is also called a Gaussian distribution. It has a nice bell-shaped curve, and with the normal curve, you're going to usually want the mean. It'll be more exact unless you have outliers that are skewing it, in which case you want the median. And then if your data isn't normally distributed and is skewed like this graph to the right, then the median's probably going to be more accurate. It's like the same thing as a normal distribution with extreme outliers. You can just see it more when you look at the curve, it's skewed. Okay, moving on to hypotheses. When you're conducting a study, you have your null hypothesis and the alternative. And depending on what type of study you're doing, they'll look a little different. So for superiority studies, the null says that there will be no statistically significant difference between each group's outcome, while the alternative will say that there is a difference between the groups. And then for non-inferiority studies, your null hypothesis is that the group receiving your intervention, their data is not non-inferior to the data of the control group. That's the null. It's important to say not non-inferior because for non-inferiority, for a non-inferiority study, failing to meet the threshold of non-inferiority doesn't mean you've proved it inferior because your study was testing for non-inferiority. So you have to say that it's not non-inferior if you don't meet that threshold. And then the alternative is that the intervention, the group that received the intervention is non-inferior to the control group. So continuing with hypotheses, the alpha represents how much you're willing to risk getting a false positive. Standard is 0.05 or a 5% chance of seeing a difference when there wasn't really one. It just happened to look like a difference by chance, which is a false positive. So you get your alpha, and then after you have all the data, you calculate the p-value, which is the actual probability that any difference you saw with your data was a false positive. It was not produced because there's actually a difference, it was just random chance. And then your p-value will be lower if you have more subjects, if you had a really big difference between the groups in your results, or if you have a small standard deviation, your data points are all really consistent. Those all make your p-value smaller, which you want. Because once you have your p-value, you compare it to your alpha, and if it's smaller than your alpha, then your data is significant, any difference you saw. The beta is how willing you are to accept a false negative, so missing a real difference between the groups. Standard is like 10 to 20%. And your power is, it's how likely your study will miss a true difference. It depends on your sample size, difference between the actual difference in outcome between the groups, and the alpha level you choose. And then your power is equal to 1 minus beta. So standard is 80 to 90% or 0.8 to 0.9. And usually researchers will decide their beta and then calculate what sample size they need to reach that power before they start the study. Okay, now, so risk ratio, odds ratio, and hazard ratio. Those are ways to express any differences between your groups. Yeah, so, okay, I remember in class we had this chart. It looked kind of like this. This really confuses me for some reason, so I don't use it, but I think a lot of people liked it, so if you did, then just ignore me, because I feel like I remember it differently. But I remember risk ratio as just being the ratio of the percent who experienced an outcome in the treatment group over the percent that experienced the outcome in the control group. I think of the percent of an outcome as being the risk for that outcome, and it's just the ratio between them. For odds ratio, so it's the ratio of the odds of an outcome in the treatment group to the odds of an outcome in the control group. And this one's kind of weird, but I think of odds like saying there's a 3-to-1 chance of something. So if there's a 3-to-1 chance it'll rain tomorrow, it means there's like 3 chances it'll rain and 1 it won't. So for odds ratio, you take the number that experienced the outcome divided by the number that didn't, and then divide it. It doesn't really make sense, but that's how I remember it. And then hazard ratio, it's really similar to risk ratio. It's just that there's a time component. So you take the percent that experienced the outcome within your time frame in the treatment group and divide it by the percent that experienced the outcome in the control group within that same time frame. And to interpret these, you have to be careful to remember to look at the outcome and decide whether you want the treatment group to have a higher or lower chance of it. For a good outcome like disease remission, you would be looking for a risk ratio or an odds ratio greater than 1, because that means that the group that got your treatment had a greater chance of the good outcome. Versus a bad outcome, you would want them to have a smaller chance. And then hazard ratio, it's usually used for an unfavorable outcome. So usually you want it to be less than 1, but it's not used as often, and usually for either death or like adverse events. Absolute risk reduction, number needed to harm, and number needed to treat are a few more ways to show what your results mean. For absolute risk reduction, you're subtracting the percent who experienced the outcome in one group from the percent who experienced it in the other group to get the absolute difference between them. The group with the higher risk should always come first. It doesn't matter if it's the control or the intervention group. You should never come up with a negative number. So you just use the higher one first and then interpret it accordingly. So for example, if 16% of the treatment group had a stroke and 19% of the control group had a stroke, you would subtract 16 from 19 and get a 3% absolute risk reduction. A number needed to treat kind of shows what proportion of your patients are likely to experience a beneficial outcome from your intervention. It's the number of patients you would need to give your intervention in order to see one good outcome. An NNT is calculated by taking the reciprocal of the absolute risk ratio of whatever outcome you're looking at. So continuing the previous example, our absolute risk reduction was 3. So you would divide 1 by 0.03 and you would get 33.333. You always run down for NNT to be conservative and not overstate the efficacy of your intervention. So to interpret that, you would say for every 33 patients treated with that intervention, you will prevent a stroke in 1 patient. And then to calculate NNT for an outcome, the outcome has to be clinically significant. There has to be a statistically significant difference between the groups for that outcome. And it has to be a yes or a no. Like you either achieved that outcome or you didn't. So either some kind of event, some kind of characteristic, or like a cutoff for a measurement. Number needed to harm, it's very similar to NNT. You calculate it by taking the reciprocal of the absolute risk difference for a negative outcome. Usually you use it for adverse effects. So you expect a higher frequency to occur in the treatment group. Your NNH is going to tell you how many people you need to treat with the drug to see 1 incidence of that adverse effect that you otherwise wouldn't have seen. So for NNH, you always round up. And to do the number needed to harm for something, it doesn't have to be statistically significant. Studies aren't usually powered to test their adverse events like that, so you don't need it, but it does have to be clinically significant and a yes or no outcome. Okay, I'm gonna go like very briefly over this. I didn't include a lot of it because we didn't really go over it in class and it's kind of dry. I put the page numbers up at the top in case you want to look deeper. It's pages in the 2021 book. So the types of statistical tests that you're going to choose to analyze your data with depend on the type of data and how many groups you're comparing. So if you have continuous data with a normal distribution, you use a t-test. You can use a t-test if you have data from one group or data from two groups you're comparing. And then if you have 3 or more groups that you're looking for differences in, you can use ANOVA. For discrete data, the chi-square test is appropriate if you have 1 or 2 groups, and Fisher's exact test can be for comparing 2 groups. Correlation is when one variable changes with or is related to another variable. It's always important to remember that correlation doesn't mean that there's a causative relationship. You always have to be looking for other factors that might be involved. And regression is a way to look at the effects of multiple independent variables or confounding factors on one dependent variable. So if you have, if you're looking at hypertension, you can look at like diet, exercise, etc. if there's a lot of variables. This is a cool diagram that shows the different types of studies put into a hierarchy based on how strong of evidence you should or you can consider the results, assuming it's a well-done study. At the top are guidelines and meta-analyses. Those have a lot of good data and evidence that's been analyzed by experts who will give you an assessment and recommendations. Next is randomized controlled trials, because they're ideally well-planned and well-controlled to minimize confounding factors. And after that comes cohort studies and case control studies, because they're observational. There are a lot of outside factors, so it's not as strong as a randomized controlled trial. And then at the bottom are case reports, narrative reviews, and expert opinion, which can still be useful, but you just have to keep in mind that it's either an event that happened in one person or it's one person telling you their opinion. Moving on to our last topic, pharmacoeconomics studies compare the costs and consequences of pharmaceutical services and products, pharmaceutical treatments. This is an outline of the different types of costs you can assess. Direct costs refer to money that's spent on the treatment itself or something related to the treatment. So if it's a medical cost, it's the money you put towards the actual cost of the treatment. And non-medical is things like transportation, lodging, and food, things that you wouldn't have spent money on if you hadn't gotten the treatment. Indirect costs are money that you lost indirectly from getting the treatment or buying the treatment. So for example, if you get a drug treatment that requires administration in the hospital, then you may have indirectly lost money that you would have otherwise earned at work if you weren't in the hospital. And finally, intangible costs are the emotional and mental costs that a treatment can have on a patient or their family. The ECHO model is a way to organize the outcomes of a medical intervention, which includes the costs and results of the treatment. Economic outcomes include all the costs that we just talked about. Clinical outcomes are the medical events or the benefits that a treatment provides, and humanistic outcomes are the effects that the treatment has on a patient's quality of life, which includes both any benefits the drug might provide for that or any detrimental effects that it has on the person's quality of life. These are the main types of analyses that you're going to use to assess the cost-benefit ratio of a treatment. So cost minimization, you are taking the costs of both interventions and just comparing it. You assume that the outcomes are equal, and you're just trying to figure out which one is cheaper. Cost effectiveness looks at the ratio of the cost of each treatment and some measurement that shows how effective the drug is. So it could be like the number of millimeters of mercury the patient's blood pressure went down, or an estimate of how many life years the patient will gain from the treatment. Cost-benefit analysis compares the monetary cost of the treatment to the monetary benefits of the treatment. Monetary benefits might be considered like future treatments that you won't need. If you get this treatment now, you'll save money from not buying them. Or if you have a patient that's really sick and they can't work right now, and this treatment is beneficial enough that they can start working, then the monetary gains that they get from going back to work would count. And finally, cost utility analysis looks at the monetary cost of the treatment and the quality adjusted life years gained from the treatment, which I'll explain a little bit on the next slide. So health-related quality of life is a way to quantify a person's well-being and the effect that a disease or treatment can have on a patient. So coming up with the actual value on it relies on patient-reported outcomes because it's all about what the patient is feeling and how their life is, not just their health measurements. Quality stands for quality adjusted life years. So 1 year of life gets quality adjusted based on like how comfortable the person is, how functional they are, their pain level, stuff like that. 1 year of life gets adjusted to a value between 0, which is no life, because if it's 0, you're dead, and 1, which would be a year of perfect health. And then disability adjusted life years looks more specifically at how functional a person is and how a disease or treatment affects their ability to function. So 1 year of life, again, gets adjusted to a number between 0 and 1. It's kind of the opposite of quality, though, because 0 means a life completely free of disease burden. You have no disability because of disease. And then 1 means a disease renders you completely non-functional. Okay, so that's all I had. There are definitely a lot of details in the book that I didn't include. I didn't want to go on for like 2 hours on this, so I tried to hit the main points. Are there any questions? Okay, I don't see any questions.